immunization services during this time and onwards. With that, let me tell you all about the flow of the session that we'll have today. We will have presentations followed by a panel discussion with our esteemed speakers, who I would now like to please introduce to you one by one. Our first speaker today is Dr. M.K. Agarwal, who is the Joint Commissioner of UIP from the Ministry of Health and Family Welfare. He guides the immunization program of the country at the ministry. He's a postgraduate in community health administration and is a public health expert. Under his aegis at the Ministry of Health, the vaccine logistics and immunization cold chain management systems underwent a major overhaul. The country received the National Regulatory Authority certification for adverse event following immunization, or AEFI management, and program communications saw a never before seen 360-degree IEC approach, which led to a remarkable shift in acceptance of new vaccines by the community. And more recently, he has been involved in formulation of guidelines on immunization services during the COVID-19 outbreak. I understand that Dr. Agarwal had another meeting at 3:30 p.m. today, so hopefully he already has joined us, or if not, then he will be joining us as soon as possible. If you're already here, Dr. Agarwal, thank you so much for taking the time to be here. Let me introduce our next speaker. It's Dr. N.K. Sinha, who is the State Immunization Officer from the state of Bihar. He's Additional Director, cum State Immunization Officer, my apologies. A surgeon by training, he has keen interest in policy, planning, and implementation of various health system strengthening interventions. He joined the State Health Department of Bihar in 1990 and worked with the WHO between 2006 and 2011, after which he has been the State Immunization Officer since then till now. During the ongoing COVID-19 pandemic, he has been instrumental in designing the guidelines for the state of Bihar for restarting immunization services and VHSND services in the backdrop of COVID-19. Thank you so much, Dr. Sinha, for taking some precious time out to be here with us today. Really appreciate it. I'll continue. Our third speaker today is Dr. Santosh Shukla, who is the State Immunization Officer from Madhya Pradesh. He is in charge Director, Public Health Department, along with being the State Immunization Officer. Dr. Shukla is a child health specialist, cum immunologist with more than 35 years of experience in public health. He has diverse experience of working in immunization as Vaccine and Logistic Officer in the Ministry of Health and Family Welfare, to the WHO SMO and NPSP for 10 years, and is currently working as the State Immunization Officer since the last 10 years in the government of Madhya Pradesh. Thank you also for being here with us today, Dr. Shukla. We appreciate your time. I will continue. Our fourth speaker today is Dr. P.C. Bhatnagar, who is the Senior Director of Programs with the Voluntary Health Association of India, or VHAI. Dr. Bhatnagar's focus of work is communicable disease control, including vector-borne diseases, TB and HIV, prevention of airborne infection and immunization. And his present responsibilities include coordination of all communicable diseases related to activities, including vector-borne disease control programs of VHAI. He's also leading the VHAI and UNICEF joint intervention on empowering community-based institutions to increase vaccine confidence and routine immunization demand and prevention of COVID-19 through promotion of key practices at the community level in 17 aspirational districts in the states of Andhra Pradesh, Arunachal Pradesh, Assam, Manipur, Nagaland, and Odisha. Thank you so much, Dr. Bhatnagar, for giving us some of your time and being here. We really appreciate it. Let me introduce our next speaker, who is Dr. Ashish Dadwal from UNICEF. Dr. Ashish is the health specialist for northeastern states, except Assam, at UNICEF India. He has a clinical experience of 10 years and has worked in critical response team at the Maldives during the 2009 swine flu pandemic. He has been associated with WHO and PSP for polio eradication and strengthening of RI services in Uttar Pradesh, and at the national level with JPIGO to prevent maternal and child mortality. Thank you, Dr. Ashish, for also coming today. I will now introduce Dr. Subhajit Bhattacharjee, who is from SRTL WHO. He's been working as a sub-regional team leader for 7 northeastern states for WHO NPSP, which he has kindly explained as the National Public Health Project. Thank you for that. For more than 3 years. He has experience of more than 13 years in various public health positions and associated with WHO NPSP for more than 10 years. The core areas of activities are health system strengthening, polio eradication, immunization, and health emergencies. Our last speaker that we have with us today is Dr. Narayan Gaonkar from the UNICEF Gujarat office. Dr. Narayan is the health specialist at UNICEF Gujarat office, where he leads the UNICEF support to government and partners on maternal, newborn, and child health programs with focus on health policy, health system strengthening, result-based management, public health in emergencies, and etc. He played a key role in mobilizing partnerships and resources for midwifery care in Gujarat. Currently, he's engaged in coordinating UNICEF Gujarat's health sector response on COVID-19. Thank you so much, Dr. Gaonkar, for coming back to the platform. You are no stranger to the COVID-19 Academy. We appreciate you coming back. Now, let me take a couple of minutes today to also introduce our 2 moderators. Our first moderator today is Dr. Danish Ahmed from WHO India. Dr. Danish is the National Professional Officer for Immunization Intensification at WHO India. He's a medical doctor with a master's in pediatrics and public health. He started his career as a surveillance medical officer in 2001 and has since remained engaged with immunization-related activities at various levels. He supported Bangladesh for control of VPD outbreak amongst the Rohingya populations, and also Timor-Leste for new polio endgame plan and introduction of a new vaccine. Sorry about that, that's my doorbell. Our second moderator today is Dr. Bhrigu Kapuria from UNICEF India. Dr. Bhrigu is a medical doctor and a public health specialist by qualification. He specializes in domains of immunization, reproductive and sexual health, HIV/AIDS, and operational research, and has worked from a grassroots level to national program management during his 17 years long career. He is currently the health specialist immunization at UNICEF India country office. That's my dog, my apologies, and is engaged in planning and implementation of strategic support from UNICEF in key priorities areas under immunization. Thank you, Dr. Danish and Dr. Kapuria, for agreeing to moderate this session. That's it from me. I have been speaking for a long time. I think I've completed all the introductions. Now let me please invite Dr. Agarwal, if you are here, to please give your presentation while I will start to screen share your presentation from my end. Thank you so much.
Hi, Asta. This is Dr. Danish. Probably Dr. M.K. Agrawal is still busy with the meeting, so okay. I apologize on his behalf. And maybe I can start the presentation. And as Dr. Agrawal joins, he will continue further.
Sounds good. Let me just screen share the presentation and then you may please start then. Just 1 second.
Thank you so much.
Thank you. I hope the presentation is visible now, Dr. Danish.
Yeah, it's visible. It's clear. Thank you so much, Asta, and thanks everyone for participation. To begin, my apologies for Dr. M.K. Agrawal not being able to attend this meeting. He got stuck in another meeting, which is still going on. So until he joins, I'll take that presentation on his behalf. So can we have next slide, please? So this presentation is in following heads. First, we'll discuss about the brief immunization program. Then we'll come to the current situation and guidelines, area classification and planning the immunization services at health facilities, and immunization services at VHND, UHND or outreach sessions, and then role of the stakeholders. Next slide, please. So as we are aware that vaccine saves lives, it prevents morbidity and mortality due to various life-threatening vaccine preventable diseases, and vaccines are very effective way for us to achieve the sustainable development goal through the primary healthcare services. Next, please. So if we look at the immunization program in India, it is one of the largest public health program anywhere. It serves around 2.6 crore infants and 2.9 crore pregnant women each year. So this is a big target, which makes our program, UIP or Universal Immunization Program of India, as one of the largest public health program. Around 1.2 crore sessions are conducted each year, and 27,000 cold chain points are there to ensure vaccine distribution to these immunization sessions. Protections are provided for 12 diseases of these through the vaccines. 9 vaccines are nationwide, which includes BCG, OPV, IPV, hepatitis B, pentavalent measles rubella vaccine, rotavirus vaccine, DPT, and TD vaccines. Whereas 2 vaccines are subnational. Of these subnational vaccine, JE is in endemic district, so it's subnational by the design of the program, whereas pneumococcal conjugate vaccine or PCV vaccine is under expansion. Next slide, please. So the program has categorized into components. The major components include policy, strategy, vaccine logistic management, micro planning, injection safeties, communication, mobilization, and demand generation, capacity building, adverse events following immunization and their surveillance, VPD surveillance, reporting and recording of the program, supervision, monitoring, and review mechanisms, and evaluation. The implementation of program is through routine immunization program, which is we know as UIP, through UIP or routine immunization program. And then we have supplementary immunization activities such as we have the pulse polio immunization programs or pulse polio immunization days with the name of NIDs and SNIDs. Then we have campaigns like special campaigns we had for measles rubella campaign. We have just concluded few months back. Then we have JE campaigns and special immunization drives such as Mission Indradhanush and Intensified Mission Indradhanush. Next slide, please. If we see how in the immunization program in India has progressed, it started in 1985 with 4 vaccines against 6 VPDs. Over the years, the program has expanded, and it has expanded with its reach as well as with the number of the vaccines that it caters. There are certain major milestones which we have had in this program over the years. In 1995, polio NIDs were initiated. In 1997, vaccine while monitor was introduced. In 2007, we have hepatitis B vaccine in our immunization program. In 2006, JE vaccine were added. 2010, measles second dose was introduced. Then we have pentavalent vaccine over 2011 to 15. It was a phased introduction in our program. Second dose of JE vaccine and open vial policy was started in 2013. In 2014, we have a major milestone of polio-free certification for the Southeast Asia region of all the countries. In 2015 and 16, IPV vaccines was introduced. In 2016, rotavirus vaccine was introduced, and simultaneously, the same time, TOPV vaccine was switched into BOPV vaccine. In 2017, we have MR, PCV, and adult JE campaign, JE vaccines. In 2019, rotavirus vaccine, which was introduced earlier, was scaled up in as a part of 100 days agenda program to nationwide. And then at the same year, we have tetanus and adult diphtheria vaccine, means our TT vaccine has been changed to adult TD vaccine. So over last 5 years, the UIP program has seen significant progress in terms of coverage as well as in terms of introduction of the new vaccines, with 6 vaccines introduced over the last 5 years. Can we have next slide, please? So again, 2 major milestones. One was polio-free certification in 2014 after having last case in 2011. And second major milestone was elimination of certification of elimination of maternal and neonatal tetanus in 2016. Next slide, please. So reaching more and more is the concept of the immunization, especially to those which are the left outs and dropouts with newer vaccine and with the improved technology. Next slide, please. And here we can see the improvement in the program scope as well as in the deliveries over the years. We have 5 new vaccines since 2014. We have talked about that. We have efforts been made to reach the unreached cohort through the Mission Indradhanush, through the intensified Mission Indradhanush, Gram Swaraj Abhiyan and extended Gram Swaraj Abhiyan, and now as intensified Mission Indradhanush 2.0. And you can see on the graph that more than 3.7 crore children and 94.6 lakh pregnant women has been vaccinated with the various antigens during these Mission Indradhanush programs, which has helped us in reaching the higher immunization coverages. There has been various innovations and use of technology and the system strengthening to improve the immunization system. Electronic Vaccine Intelligence Network, what we call as EVEN, is one such innovation which is being used. It helps us in providing the real-time stock management as well as cold chain management status. The ANM Online or UNMOL is a system to have a real-time data reporting using the tablets. Then we have Kilkari, which is a audio messaging system to pregnant women and caregivers of the children to remind them for their due antigens. Then we have cold chain resource centers at Delhi and Pune, fully functional now. We have National Cold Chain Management Information System, what we call as NCC-MIS, in place, and effective vaccine management assessment system is there, which is done periodically to assess the cold chain status across country. Next slide, please. So coming to the next major topic, which is immunization during the COVID pandemic. It's a challenging type for all of us. However, with the resilience and with the adaptation to the local context, we hope we will be able to continue the gains that we have made over so many years in the immunization. Next slide, please. Before I move to the immunization in COVID, let us see what are the current situation and guidelines with regard to COVID, which will help us to understand how we can function immunization in such a time. There is an order from Ministry of Home Affairs of 15th April, which defines that all health services are deemed essential and need to be functional across country. Immunization is one of the essential health service which should be continued during COVID-19 outbreak to protect children and pregnant women from the vaccine preventable diseases. An increased cohort of unimmunized children is a risk for VPD outbreak and need immediate addressal. Based on existing COVID-19 situation, districts, sub-districts, or other administrative units has been categorized, and this is a fluid situation which changes every week depending on the local epidemiology of the COVID. So districts or the areas are classified as red or orange zones, which depends on which are those areas where we have active COVID cases, and then there are green zones where we don't have active COVID cases. Within each red and orange zones, the COVID-19 cases are defined in the areas of containment zones. These are zones, areas, or locations where we have cases or cluster of COVID cases. It depends upon the epidemiology of the area, how it's defined. Surrounding that containment zone is a buffer zone. And then we have areas beyond buffer zone in red as well as orange zones or districts. Next slide, please. So for the immunization services during the COVID, there is a letter from the Ministry of Health and Family Welfare, which is there, which was released on 20th May 2020. there are certain guiding principles. And these guiding principles are that guidelines from Ministry of Home Affairs and Ministry of Health and Family Welfare pertaining to COVID and related updates will be primary reference points, and no state should violate the COVID-19 guidance. So COVID-19 guidance is the first and primary things which should be adhered and followed. Practicing of social distancing, hand washing, and respiratory hygiene need to be maintained at all immunization sessions by all beneficiaries as well as service provider in all sessions, irrespective of the district categorization. Bird dose vaccination at health facilities would continue irrespective of district categorization, as our targets are those which are institutional deliveries. So during the institutional deliveries, the bird dose vaccination, which includes our 0 dose of polio vaccines and hepatitis B 0 dose, they should be provided irrespective of the district categorization to all births in the institution. Then immunization services are delivered through 3 platforms. One is bird dose vaccination, as I described just now. Then we have health facilities based sessions where immunization are organized at the health facilities such as district hospital, community health center, primary health center, sub-center, etc. Then the third category is outreach sessions, which are there when health worker goes in the community and set up the immunization sessions at villages or urban areas in mohallas, along with the nutritional days, which we called as UHSND or BHSND services. Next slide, please. So drawing from the area categorization of the COVID, we have tried to align the immunization services so that it's easy to understand and implement along with the COVID. So there are immunization in containment zones and buffer zones. And second part would be immunization in area beyond buffer zone and green zones. So within the containment and buffer zone, so these are areas in red or orange districts. Active immunization services are not there. So health facilities based sessions will not be organized and outreach sessions will not be organized. However, if there are beneficiaries which are there in the health facilities and are demanding for the immunization, the vaccination services will be provided to those. In the areas beyond buffer zone, in red and orange districts, and then in the green districts, the immunization services will be provided at health facilities as they are going on without any changes. However, there would be certain modifications in the outreach sessions, that is VHND and UHSND in the areas. Let me explain it further. Maybe if we have next slide. So when we talk of the containment and the buffer zone, so those are the, if you recollect the 3 or 4 slides before, we have a diagram showing through the circles the containment zone having some cases and then surrounding the buffer zone. So I'm talking about those areas. In those areas, we will not be having the health facility based sessions in general. However, if there is some demand or some beneficiary has already walked into the health facilities and asking for vaccination, the vaccination will maybe provided to those beneficiaries. There would not be any active mobilization for the health facilities. At outreach, we will not have the outreach sessions at those places. So every opportunity will be utilized to vaccinate beneficiaries if they are already in the facilities or they are reported in the facilities. The social distancing, hand washing, and respiratory etiquettes will be followed during these immunizations. And vaccination of the pregnant women and the children who have reported to these facilities will be undertaken. Any area exiting the containment zone or buffer zone can start immunization services as the area beyond buffer, because these are fluid. If there are COVID cases, the area will be defined as containment or buffer zone. After a certain period, when they are over from containment or buffer zone, the immunization services will be resumed as usual, as defined in the areas beyond buffer zone. However, state and district administration to make the local assessment of the COVID-19 risk before the starting. Similarly, if there is some area which is enlisted as containment or buffer zone because of fresh identification of COVID-19 cases, they should stop the health facilities based and outreach based session as defined in this table. Next slide, please. For immunization services in areas which are beyond buffer zones and green, which are basically green zones. So health facilities based sessions will be there, yes, and outreach sessions will be there. So all areas beyond buffer and green zones will follow the same guidelines. However, there would be certain modifications for outreach sessions, and what these modifications are. First, one outreach session will be planned for less than 500 population to limit total beneficiaries of 10 to 15 per session. A staggered approach will be followed for each session to avoid crowding. At a given time during the session, not more than 5 people should be there at session site, with at least 1 meter distance between each. So we have to plan accordingly. That there is a modification in our planning to adhere to these norms. The organization of such sessions will be at the discretion of the district administration, with clear planning for social distancing and hand washing at the session site. Next slide, please. There are certain standard guidelines for outreach sessions irrespective of district categorization, which means if we are having an outreach session irrespective of category of this district, we have to follow these guidelines. Universal prevention and control principle of COVID-19 to be followed at each session site. All outreach sessions to be followed by staggered approach, and community mobilization strategy to be adapted accordingly to prevent overcrowding at session site. Pre-identification of session site with adequate seating space for beneficiaries and caregiver while maintaining the social distancing of more than 1 meter, with a clear area demarcation for incoming beneficiaries, post-vaccination waiting area, and a reserve zone if gathering increases. Number 4 is support from the panchayat and local urban bodies to be sought for identification of appropriate session site and space to practice social distancing of at least 1 meter. Various session approaches to be adopted in all the districts for immunization services. What does these means? This means that maybe we have to look back to our microplan, routine immunization microplan. At time, you have to increase the number of sessions. At places, you may have to change the session site location so that you have adequate space for social distancing and such things. Next slide, please. So if we summarize how immunization services will be there during the COVID, so we can have all districts, then we have within districts, containment and buffer zones. In those areas, there would be in general, no immunization, except for the opportunities such as if a caregiver or a beneficiary is there at the immunization session, they will be provided with the immunization. At health facilities, outreach sessions will not be there. In the areas beyond buffer zone and green zone, both health facilities as well as outreach sessions will continue, but dose vaccination for all health facility deliveries will continue irrespective of district categorization. Next slide, please. So there are certain prerequisites arrangement if we are having the immunization sessions. I'll start with the immunization services at health facilities. We have to have pre-identified and well-ventilated seating area with demarcated seating locations 1 meter apart, an adequate number of pre-identified fixed vaccination staff depending on the injection load and required documentation. Staff conducting vaccination should wear 3-layer surgical mask and a glove and sanitize their hand after vaccinating each child. Support staff to manage seating area, queue management, etc. for the pregnant women and caregivers. Ensure hand sanitizer and hand washing units available for the public use at the entrance of the health facilities. Disinfect seating area after completion of the immunization session. Adequate availability of maternal and child protection card and due updation of the records after vaccination. Adequate availability of the vaccines and logistics for the uninterrupted immunization session. Display visual alerts in the clinic, such as posters and with informations about COVID-19 disease and reminders for individual prevention strategies. Next slide, please. Can we, yeah. So these are some of the pictures you can see from the Tripura we received. The social distancing at the waiting area in the first picture. Then we have immunization using the personal protective equipments, ANMs wearing, and the vaccinators wearing the 3-layer mask, as well as the caregivers also need to cover their face. And then the waiting areas and other areas. Next slide, please. At the VHND and UHND or outreach immunization sessions, plan for multiple small sessions in the missed area through a catch-up approach and initiate VHND, UHND and RI session as per microplan. We understand that during the days over the past few weeks, immunization services may have been not as usual and may be disrupted. So there may be a backlog. We need to clear those backlogs, and those backlogs clearance may need some additional catch-up sessions which needs to be planned and implemented. Can we have a tab, please? Next slide, please. Yeah, thank you. For session organizations, a staggered approach needs to be adapted. This is to avoid crowding at the immunization sessions, and we need to practice this staggered approach. For each session, we can divide children and pregnant women as per due list into the hourly slot, so that for every hour there are 4 to 5 beneficiaries allocated. Additional doses and accordingly they would be mobilized. There may be need for additional doses for reconstituted vaccine, because there are certain vaccines such as BCG, measles and JE, especially measles and JE vaccines, which we cannot use for longer duration. We may need additional doses of those vaccines. So that needs to be factored in while we are planning and doing the vaccine mobilization for the session sites in such a situation. Identify alternate site in case there is a space constraint which is limiting the social or physical distancing, and there is lack of adequate provision of hand washing with soap and water. So we may have to find some alternate spaces where we can have such place for the distancing. Schools, panchayat ghars and community centers, marriage hall, etc. could be some of the provision. So these needs to be explored as an alternate sites. Then there could be breakup sessions. One village sessions may be divided into 2 sessions to reduce crowding if a staggered approach does not suffice. This is important if the village is big or is spread over a larger areas, then you can have a session for few hours at one place and few hours at other places. But again, you have to take care of additional vaccines and logistics, especially the reconstituted vaccine at such a place. There could be additional sessions may be planned, and there is a provision to conduct which can be conducted by provision of hiring vaccinator. You can think of retired ANM or health staff which can be hired, or a trained male health worker at subcenter, LHV, male health assistant at PHC, etc., who can provide the vaccination at these additional sites. Then we can have immunization services through the mobile teams. Can we have a tab, please? Next slide, please. Okay, so through these mobile teams, which can identify and reach hard to reach area and deliver the immunization services. The key components for VHSND or UHSND or RI sessions means the key outreach sessions. For beneficiary mobilizations, we have to have these considerations. Based on agreed hourly slot, ASHA should mobilize beneficiary or family of beneficiaries by phone at least 1 day prior to the session. So they should be informed about the session, the time at which they are expected to come at the session beforehand. Then on the day of immunization or on the session day, ASHA and Anganwadi worker or mobilizer will mobilize beneficiaries as per hourly plan while taking due precautions of the social distancing and hand washing and sanitization, respiratory hygiene, and may use the community may use the home cloth made mask during the visits. Request for only one caregiver to accompany with the beneficiaries to avoid overcrowding and maintain effective social distancing. Any child caregiver or pregnant women suffering from flu-like symptoms such as fever, cough, shortness of breath should be asked not to come to the session and seek the guidance as per COVID guidelines. For the session sites, A&M should wash hands with the soap and water for at least before and after the 20 seconds before the start of the session, and sanitize hand with alcohol-based sanitizer before and after vaccinating each beneficiaries. Adequate arrangement of soap and water and other necessary equipments would be needed. A&M wear a triple layer surgical mask and a glove. All caregivers should advise to use homemade cloth mask during the visit to the session. Ensure adequate availability and appropriate distribution of ORS, zinc, iron, folic acid, calcium, mother and child protection card, and other items as per VHND guidelines. Next slide, please. So for waiting area, ensure beneficiaries and caregivers maintain social distancing during the 30-minute waiting period, which is post-vaccine inoculation. This 30-minute waiting period may be used for group counseling, giving the community some important messages, avoid individual counseling. Provide key preventive message related to COVID-19, such as hand wash, technique, nutrition, pregnant women, and breastfeeding, etc. So mobilizers and other people who are there to support the session may use this vaccination for this time for gainful messaging. After the session, after all beneficiaries are gone, the site should be sanitized properly. That means tables, chair, weighing machine, and other equipment such as BP instruments, etc., which are there at the session sites. Glove and mask should be properly disposed as per guidelines of the COVID-19. All vaccine and logistic along with the biomedical waste should be taken back by alternate vaccine delivery. Some other related components includes the capacity building of frontline health worker. Instead of in-person training, existing digital health platform may be leveraged for training and the capacity building. Now there are ANMs with Anmol tablets. There are many Ashas with smartphones. So those opportunities should be looked and utilized for the capacity building of our health worker. Vaccine and logistic availability needs to be reviewed for the availability. In general, the near expiry and stock refilling of even guidelines needs to be followed. Vaccine to be added to COVID priority list. Ensure VPD surveillance is continued so that we are generating the evidence about the VPDs. This is the time when if we are having some disruption in the immunization program, the risk of VPDs increases. So with that, at that point of time, we need to have a vigilant surveillance system to capture any early warning signs of these VPDs. Expand supportive supervision of the session and add COVID-19 related indicator in the monitoring checklist. We are working on that. We'll get back on soon on this. Next slide, please. So here are some of the pictures from the outreach sessions during the COVID. You can observe that these are pictures from the field. These are the real picture from the UP, Bihar, Tripura, Nagaland, and some other parts. I hope we will have some more examples as as we have the examples from the field or experience from the field over the next presentations. Next slide, please. So about the stakeholders on the immunization program. We know that immunization program in India is huge, is probably one of the largest public health program. So to run such a program, we need to have stakeholders, and there is roles and responsibilities which a stakeholder have in such a program. Maybe if we have next slide, please.
Dr. Danish, sorry to interrupt. I was just issuing a kind reminder that we're running a little bit behind time. If we could wrap up this presentation in a bit would be great.
Thank you so much for reminder. I'll try to be fast.
Thank you.
So
Thank you.
on the stakeholders, we have different stakeholders for the immunization program. I'll talk about health professionals, including the private sectors, academia, and professional bodies. Over the years, they have been supporting the immunization program in generating the awareness, spreading the messages for the vaccines and their importance. They are endorsing involving the government immunization drive. They are supportive supervision being provided by the medical colleges, and the vaccination is in the agenda for their awareness creation and advocacies. So we hope that the same role would be required even more in the COVID-19 situation. There are global agencies and partners which are providing technical supports and innovation and use of new technologies, supporting evidence-based generations and data and decision makings, generating demands and encouraging the partnership for intersectoral synergies and capacity building. Then there are line ministries which are supporting special immunization drives, participation in the review meetings and providing support, provision of the vaccination space, which is critical again for in the COVID-19, which is a new concept in this background, involving supervision and providing feedback and supporting the IEC component of the program. Can we have next slide? Then we have civil society organizations, NGOs, and CBOs. They are providing the support to immunization by promoting immunization and building the community confidence. They are supporting the local decision makings, mobilization of the community through influencers, and supporting the empowering the vulnerable communities, supporting the capacity building and community tracking progress and implementation of the changes, supporting A&M for the site identification, which is again critical for this COVID-19 background, and support awareness generation and mobilization, and with the messaging of the special areas like conflict areas and vulnerable sections. Role of media is critical and important in understanding and advocating the benefits of the immunization, support accurate reporting and negative or false alarm or sensation in the press, use authentic source and support in counteracting myths and the false messages. So thank you. That's all from my side. And over to you, Asta.
Sorry, I'm not sure how that happened because I'm not very sure that was the end of the presentation. But Dr. Agarwal is here, and maybe if he would like to say a few words as well. Dr. Agarwal, if you can hear me, you can please unmute yourself.
Hello, everybody. I'm sorry that I could not join in the webinar. Though I promised to join, but there are some important works in the ministry, and we have to organize something for the basically global summit, which is coming up on 4th June. And there are some urgent works related with that. And besides that, we had a call from Geneva on certain issues on vaccination. I have to support my joint secretary and additional secretary for that. I'm sorry that I could not join in, but my message is loud and clear that vaccination should not suffer in these trying times of COVID, and every state and UT has to basically provide immunization services as per the guidance document which has been circulated to all the states and UTs. And my best wishes for your webinar, COVID webinar on providing essential services like immunization. I will not be able to continue with the webinar as I have to again finish the works which I have started in the morning. Thank you all. And I could see Dr. Sinha. Hello, Dr. Sinha. Yeah. And Dr. Shukla is also there most probably. And Dr. Brigu, Dr. Danish. I'm thankful to all for organizing. I'm thankful to UNICEF and WHO for organizing this webinar. I think such kind of webinars should be organized to educate about availability of immunization services across the country. Thank you all. Bye-bye from my side. Okay.
Thank you, sir. Thank you so much for joining in, sir.
Thank you. Thank you, Guru. Thank you. Okay. Bye-bye.
Thank you, sir.
Okay, friends, thank you so much. And thank you, Asta, for taking this forward. And thank you for coordinating that. And a big thanks to Dr. Danish for taking this, because Dr. Agrawal got stuck in some, as he said, there was an urgent last minute thing. And but he promised that he will be there with you. And you saw his message and his slides getting disseminated with Dr. Danish. So thank you so much, Dr. Danish, for being part of this. This is a very important juncture where we are standing. As said by the speakers, immunization is one of the core essential services, public health services that we give to a child and to pregnant mother. And the other important point about immunization is it is a very valid example of partnership and collaboration. This program does not work without the vaccine. So it has a very clear understanding and a partnership from the suppliers. This program does not work without the engagement of the community and the community mobilizers. So it has a very clear understanding from that side. This is a team effort in immunization, and with these 800 people sitting on this webinar, that team effort is very clearly depicted. Under the leadership of government, both at national level and state levels, you see the Ministry of Health coming in, you see Dr. Sinha sitting there, you see Dr. Shukla sitting there to be part of that. So led by the government, supported by development partners like WHO, UNICEF, UNDP, ITSU, CHAI, NCC, VMRC, and everyone, BMGF, PATH, everyone coming together. And then supported by the community from very clear grassroots workers, NGOs, CBOs, CSOs, everyone coming together. Again, on the other end, supported by professional bodies like Indian Academy of Pediatrics, Indian Medical Association, Nursing Association, everyone. And finally, last but not the least, our entire private sector, the doctors providing that. So everyone coming as a team to ensure that in my country, a child should not die because of vaccine preventable diseases. And I think there could be nothing more rewarding than this. So to take this forward, this interesting thing, let me invite a few of our people. So in the first half, you saw what the Government of India as Ministry of Health released guidelines on immunization. I can proudly say that on 24th of April, on the eve of World Immunization Week, Ministry of Health had a discussion with all the states how to restart immunization. So from 24th of April, this entire muhim, I can say that in Hindi, that entire thing started across the country. And that was taken forward by stalwarts who will present now as to how things are happening at the state. So to take this discussion forward, let me invite Dr. N.K. Sinha from Bihar to share his experience of how these guidelines were actually translated into field level implementations in Bihar. Dr. Sinha, thank you for joining in, and over to you, sir.
Thank you, Dr. Brigu. Thank you so much. And I would like to thank everybody who is involved in hosting this meeting. Though Dr. Agrawal is not there, I'd like to thank him for this timely intervention. At the outset, I would like to thank the Government of India for one thing, that all the vaccine which is available with Government of India is available in Bihar. And things like vaccines we can see that the 12 diseases for which vaccines are there, we are having in across the state which JE has been introduced, is likely to be introduced. We were going to have some we had have campaign, immunization campaign of JE in 24 districts, and then again we are having in we were supposed to have, but because of the COVID we got stuck. And next slide, next slide. Yeah. So you know that we are just covering 1/10 of the population of the country, and but the cold chain, you can say, because of the time and some I think I need not be reminded that you have taken extra time, so I'll try to be a bit fast. So we are having 10% of the population, and but the sickness rate of the cold chain, I'd like to tell that we are having only 2% of the cold chain point with such a big thing. And though we want to increase it, because of the lack of infrastructure and all, we are not able to, but we are maintaining the cold chain sickness rate at around 2%. And full immunization coverage, you know that we are matching this country level. Next slide, please. Yeah. Yeah, the challenges which we had initially, which was something which is very easy to stop, but to restart, you know, the moment of inertia. Then it's at 16th March, it was a JE campaign. As I said earlier, it was supposed to start, and then lockdown was there. We could not do it, and then our ANMs, ASHAs, all our health facility people were put in quarantine center, isolation centers, and all those things. We were just not able to do anything. So, and whatever in the fixed sessions, which we are selling, that whosoever comes to the fixed sites, they were given vaccines, but the numbers were so less that it was practically as good for nothing. Next slide, please. Next slide. Yeah. And then what happened that we wanted to increase how to go ahead, that when we called a technical committee meeting, and technical committee meeting, we had a technical committee meeting, and then how to start and how to what precautions. What the good thing which we did, that we took all precautionary measures. We gave gloves and sanitizers, and all the guidelines of the national levels were followed. And one good thing that the government of Bihar did, that all the frontline workers will be included for that 50 lakh cover if anything goes wrong with them. So, and then we released a training video disseminated, and we are happy that it was shared by ASMD in the entire ACPIO's group. So, and reappropriation of short expiry vaccine, that is also becoming a pressure on us, how to manage with the vaccine which was likely to expire very soon. So the EVIN, again, Dr. Danish had mentioned, it had supported us in a very good way, and we used that opportunity. And I'll tell you some more things about it in the next slide. Next slide. Next slide, please. This is not. Then you can say that we started our services, resumed on 6th of May. Daily reports being collated, and as of now, we can say that we have covered 1.3 million children and 0.43 pregnant ladies. The children is 12 lakh written here, which is increased as of now. And the 79% of the sessions are being planned, somewhere 80, sometimes 75. It ranges from 49% to 100%. So we are adding sessions also, that the session backlog sessions we are adding, and the footfall in these children, these sessions are increased in the, as when it is compared to the previous thing, it has increased to 13, 14, and the pregnant women are coming to 4 to 5 per session. So these things which we are doing, and we are taking all precautions, and Government of India has shared their views, and we keep talking to them, and they are supporting us in every aspect. Next slide. Next slide, yeah. Ongoing challenges, involvement of few NMs in the other works, containment zones. It's a very dynamic situation, is very fluid. It changes overnight, and completion of updation of the due list. Another thing will be that migrants are coming, the pregnant ladies are coming, our teams are visiting the session sites, ASHAs are going and calling them, and we are giving more emphasis on the people who have come from outside, especially the pregnant ladies. And that is how we are managing the challenges to a very great extent. So these are all we had to say. If I can say that we had a small video made by our ED and messages how to present. If time permits, you can play that video. Otherwise, it's okay for me.
Right. Let me just. Thank you. Thank you for that, Dr. Sinha. Should I go ahead and play the video? I actually have it loaded up. It'll just take me a second.
So nice. So nice of you. So nice. It will be very rewarding for the team.
Thank you.
राज्य में कोरोना के संक्रमण को देखते हुए आउटरीच एक्टिविटीज में जो भी एएनएम और आशा सम्मिलित हैं उनसे अनुरोध है कि इन आउटरीच सेशंस का इम्यूनाइजेशन के लिए इस तरह आयोजन किया जाए कि सोशल डिस्टेंसिंग संबंधी नॉर्म्स का पालन हो।
बिहार में VHSND अर्थात टीकाकरण सह आरोग्य दिवस 6 मई से पूरी सावधानी और सतर्कता के साथ प्रारंभ कर दिया गया है, जो इस वीडियो द्वारा प्रदर्शित की जा रही है। कोल्ड चेन हैंडलर अपने आवास से ही मास्क पहनकर आएं और सबसे पहले अपने हाथों को साबुन से अच्छी तरह धो लें अथवा सैनिटाइजर से अपने हाथ साफ कर लें। उसके बाद ही कोल्ड चेन पॉइंट में प्रवेश करें। अपने दैनिक कार्य को प्रारंभ करने से पूर्व हाथों में ग्लव्स पहन लें। CCH के लिए नॉन स्टेराइल ग्लव्स का उपयोग पर्याप्त है। AVD या कुरियर भी मास्क का उपयोग करें एवं CCP में आने से पूर्व अपने हाथों को धो लें या सैनिटाइज कर लें। एक बार में 1 या 2 ही AVD अथवा कुरियर CCP में प्रवेश करें ताकि सभी लोगों के बीच उचित दूरी बनाई जा सके।
मेरा नाम राकेश कुमार श्रीवास्तव, मैं प्राथमिक स्वास्थ्य केंद्र दानापुर में। जितने भी हमारे कुरियर आते हैं उनको सर्वप्रथम पहले मैं बोलता हूँ हाथ धोने के लिए, उसका सैनिटाइज में करवाता हूँ। उसको करवाने के बाद उसको वैक्सीन देता हूँ ताकि वो टीकाकरण सत्र स्तर पर बढ़िया से ले जाया जा सके।
आइए अब देखते हैं कि VHSND सत्र पर किन सावधानियों का पालन करना है। ANM, आशा और आंगनबाड़ी कार्यकर्ता अपने आवास से मास्क पहनकर ही आए एवं सत्र स्थल पर अपने हाथों को साबुन और पानी से धो लें। ANM, आशा और आंगनबाड़ी कार्यकर्ता भी सत्र की तैयारी के समय आपस में उचित दूरी बनाकर रखें। किसी भी कार्य को प्रारंभ करने से पहले ANM ग्लव्स पहन लें। सत्र स्थल पर 1 मीटर की दूरी पर गोले बनाए जा सकते हैं जिससे फिजिकल डिस्टेंसिंग का अनुपालन सत्र संचालन के समय किया जा सके। लाभार्थियों के हाथ भी साबुन और पानी से धुलवा लें। सत्र का संचालन पूर्व की तरह ही होगा। सभी वैक्सीन पर खोलते समय दिनांक और समय लिखे जाएंगे। प्रत्येक टीके के बाद सिरिंज को हब कटर से काटकर सभी वेस्ट का निस्तारण गाइडलाइंस के अनुसार करें। प्रत्येक लाभार्थी को टीकाकरण के बाद 4 महत्वपूर्ण संदेश दें और उन्हें सत्र स्थल पर 30 मिनट तक बैठाएं। यह ध्यान रखना है कि लाभार्थी का मुंह, नाक मास्क अथवा कपड़े से ढका हो। ANM द्वारा प्रत्येक लाभार्थी को टीका देने से पूर्व सैनिटाइजर का उपयोग अनिवार्य है। यह किसी भी प्रकार के संक्रमण को रोकने में काफी सार्थक रहेगा। स्वास्थ्य केंद्रों में संचालित टीकाकरण सत्रों में भी इसी प्रकार के सावधानियों का पालन करना होगा।
अभी COVID-19 को देखते हुए सभी को सोशल डिस्टेंसिंग और मास्क अनिवार्य रूप से लगाने के लिए बोला जा रहा है और हम लोग भी प्रत्येक बच्चे का वैक्सीनेशन के बाद
वीडियो चला गया। ऑडियो वीडियो क्या हो गया?
Sorry, it just stopped in the middle. Let me try again. I'm so sorry. It seems that there's some issue with the audio. Sorry, everyone.
No issues.
I'll stop sharing this now. Thank you for watching this far.
So thank you so much, Dr. Sinha. This has been a great experience sharing from Bihar, and I congratulate you and your entire team for taking this effort forward and ensuring that immunization does not suffer during the COVID. We protect our children also from vaccine preventable diseases, and we protect our children and everyone from COVID also. So thank you for taking this time and sharing this forward.
Thank you so much. Thank you.
moving on to this journey, next in line, we have Dr. Shukla sir coming in from Madhya Pradesh and bringing in a different kind of example of how Madhya Pradesh has taken forward the entire effort towards ensuring immunization services, even during this COVID pandemic. And I invite Dr. Shukla to please come and present how Madhya Pradesh has taken up this challenge and how are you addressing and what can you guide to the other parts of the states and the countries and other countries as well. Dr. Shukla, please.
Good evening, Dr. Bhragu, Dr. Danish, Dr. Sinha and my viewers. Namaskar. I will start in Hindi. बदलते वक्त के साथ बदल जाती हैं मान्यताएं, अपेक्षाएं, आवश्यकताएं. What COVID-19 has given us a lesson that we will have to change according to the need and the situation. And my theme of today's talk is that we will have to think beyond so that children of this nation are immunized. There should not be any fear complex so that we can live with the virus. This is my theme. Next slide. Full immunization is every child's birthright and it's our combined responsibility. Let us fulfill it. Next. What happened actually, what Dr. Sinha was telling us, that same thing happened in Madhya Pradesh also. Because of the lockdown, there was no public transport system available for moving out to the ANMs. Because of the lockdown, the beneficiaries were not coming out. Because of the lockdown, everything was totally disturbed. Even our Anganwadis were closed. So what to do then? What we decided in the green areas, luckily that time 9 districts were in red, rest were, we have got 51 districts, so rest were in green area. So there was a national VC and Madam Gurnani told us that you should start vaccination in green areas. So I submitted one problem to her that because of the lockdown, public transport system is not existing. And she guided me that you should come out with some innovative idea. And what we did was we had an integrated mobility support system through NHM. And that was, we have 89 highest tribal blocks in the state, in the country. So we have supported extra mobility support in those blocks through NHM. We have got MMUs and we have got RBSK 2 Gs per block. That helped us to move our workers to the outreach session, and we continued with that. And there was a briefing done by, there was news in the Times of India. They found that immunization in tribal belt have increased in respect to the last year. And because it was migration which is coming in, so I've got very good DIOs on the borders. We are surrounded by 5 states and one of the highest migrant state in the country. Till now, 15 lakh migrants have entered inside Madhya Pradesh border. And luckily, we designed a format, we documented and we computerized it. And we filtered age-wise. We have got 1.80 lakh children to be vaccinated. That number we have, and we have planned for vaccinating those children in coming days. When we analyze how much difference was there in session holding, 26,000 sessions we missed. So we, under instruction of PS and MD, we developed a catch-up round plan, and now till today we have completed 10,000 sessions. We have completed 30,000 immunization done in the children, and 10,000 pregnant women are vaccinated. So we are picking up all those losses we had. Next, we started through our ASHA and Anganwadi. You are seeing that now we are changing our communication system also. Now we are using mega mic system to invite our beneficiary. We have developed a beneficiary groups, and our communication strategy is also changed. Next slide. Next slide. Yes, all those practices which are needed to meet the challenge of COVID, hand washing, use of masks, and sanitization, everything we are using. Next. what you are looking here is we have shifted our immunization session where population is big, we have shifted into schools. And because you are seeing that we have got an entry point, we have got the exit point, we can maintain the distance, and we can have all those protocol in place if we have that facility, because you know all schools are closed next 2 to 3 months. So we have already shifted our session site into the schools. What is this SMS? SMS is a new communication word I coined, because you know there was so much negativity in the country about COVID. We were only talking in the media cases and death, and that created a panic. So because I was one of the contact person of positive cases, there was unfortunate incidents in my directorate, so that I was using all those practices. SMS means sanitizer, mask, and social distancing. And when my report came, it was negative. I developed faith that this strategy is the only way to meet out virus. When I was in the quarantine and I SMS to my secretary, ma'am, you have seen me wearing all those masks and my report is negative. So I have developed a faith, and it is my submission, if we can have a resolution and an act of the state that all should wear a mask, it will be a game changer. And you don't believe it was that message was WhatsApped at 4 p.m. and at 6 p.m. our chief minister was saying through TV media that from next day Madhya Pradesh will be having this act and it will be a punishable act, so that chain can be broken down. When mask was to be used, it was with the intention. But again, I got contact of my steno, and that time again I had to be quarantined. And then again I thought, once I have protected myself against the virus twice, this SMS is going to be the only answer in the country. And then I said to my workers, you immediately take to the wall paintings. At 8:20, one of the best, next slide, one of the best BCM I have in district Guna, and he's in the blue shirt. Next, when I told him that you should develop this on walls, he immediately got it done. And now every ASHA in the state is confident that if we can use all these masks and sanitizers and social distancing, we not only prevent ourselves, but also prevent the community also. So that has changed the scenario. It's a fear complex. The community is also now accepting that. I am going to other district slide, Chabua. It is highest tribal populated, 85% population is tribal, and the surrounding state is Gujarat. The population goes for as a laborer for 7 to 8 months. Because of this problem of labor coming back, we designed beautifully. We designed one thing. We designed a migrant format. We captured all those data which were needed so that we can have a immunization data with us. And the DIO, Dr. Rahul, he did a marvelous job. He could pick up all those migrants, families, total data, and we have now till date 1.80 lakh children are with us, computerized, name listed, break up into the age wise, the antigen wise. That data is with us. Next. All those were screened, whether it was in bus station or railway station. Every team was there, not only to screen medically, but also to document. Next. Now we have started sanitizing in our cold chain room. We are sanitizing our vaccine van. We are sanitizing all those areas which are concerned with immunization service delivery. Next. Next. This is the plan name wise. Can you come back? This is the plan made at Jhabua, and all now districts are maintaining it. You can see the name of the child, which vaccine is to be given on which date. Next. Next. Urban immunization, a big challenge. And I'm thankful to my Indore team. Unfortunately, they are suffering with COVID-19, one of the highest cases in the country, but they have designed how to run the immunization session in the outer area. They have picked up 15 schools, and all schools collector took the lead. He not only involved the other departments, but also sensitized and motivated the workers to start vaccination. Next. So school session planning is done. 3 ANMs are picked up. A big hall is there to immunize. We are running session 9 AM to 3 PM, and the token is given. If there is rush, we give token. All social distancing is being maintained, and Anganwadis are mapped. Near that school, Anganwadis are also mapped. And also we have asked the private practitioner, whosoever is there in that area, they are pushers, they are motivating for the beneficiaries to come over there. Next. This is the map of city. You can see those red dot areas which are depicting the school building out of buffer area. Next. This is the scene of inside school building. You are seeing that we have used all those furniture which were being used by the school persons, and we are maintaining the social distance. Next. This everything is now, vaccinators are wearing face. We have started giving face shield also, mask, gloves to the workers, and thermal gun and pulse oximeter also in the urban areas. We are maintaining high quality vaccination sessions. Next. We are not allowing any ILI or SARI persons, and anybody who is more than 60 years is not allowed to come at the session site. That precaution we have. Next. Next. You see, when there is rush, we ask them to sit and wait. And there is miking system in the school we are using also. We are sensitizing how to prevent yourself, and we are asking to come one by one. Next. Parents are cooperating, and till date 10,000 children have been immunized so far in last 7 days. AFI kit we are maintaining all those which are required for successful holding sessions. Next. Next. One beauty thing was, there is one COVID control room center which are receiving so many queries, and through that system, that PO system, we are suggesting that if you have got children, we have managed this immunization session, you can go to that place. So that is one of the advocacy, and you are seeing that SMS message, Corona ka ant hoga kab. It is a very positive message. Corona ka ant hoga. Nobody is saying ki Corona ka ant kab hoga, but everybody is asking. So I came out with the answer, Corona ka ant hoga kab. SMS follow karoge tab. S means sanitizer, M means mask, and S means social distancing. Next. Next. A small video film.
Sorry, just started. Please go ahead.
This is a small video message we have developed for the workers as a training tool through the support of Chai. And if you can run, it will be good for a minute.
Of course. For a minute then. Okay.
Yeah. Just to have a feel of animation.
ठीक है. Okay.
नमस्कार। मातृ एवं शिशु मृत्यु दर को कम करने के लिए कोरोना महामारी के दौरान भी सभी राष्ट्रीय स्वास्थ्य कार्यक्रम संचालित किया जाना अत्यंत आवश्यक है। ये फिल्म स्वास्थ्य कार्यकर्ताओं को बदली परिस्थितियों में काम करने के लिए मार्गदर्शन प्रदान करेगी। मुझे पूरा विश्वास है कि हम सब मिलकर प्रदेश को कोरोना तथा टीकारोधक बीमारियों से निजात दिला सकेंगे। धन्यवाद।
It's address about Principal Secretary. Yes, sir.
नमस्कार। इस वीडियो के द्वारा हम आपको कोरोना से बचाव के प्रोटोकॉल को ध्यान में रखते हुए टीकाकरण सत्र आयोजित करने के बारे में बताएंगे। टीकाकरण सत्र के एक दिन पहले हितग्राहियों के परिवारों को सत्र स्थल एवं उनके लिए निर्धारित किए गए समय के बारे में बताएं। इसके लिए मोबाइल का उपयोग भी करें। बाहर से आए परिवारों की जानकारी लें एवं यदि कोई हितग्राही उन परिवारों में है तो उन्हें टीकाकरण सत्र में आने को प्रेरित करें। साथ ही समझाएं कि हर हितग्राही के साथ केवल एक देखभालकर्ता आए जो 60 वर्ष से अधिक उम्र के ना हो। जिनको सर्दी, खांसी और बुखार हो वह सत्र स्थल पर न आए। घर का बनाया हुआ कपड़े का मास्क हमेशा पहने। सत्र स्थल का चयन कोरोना अस्पताल या क्वारंटाइन सेंटर को सत्र हेतु न चुनें। स्वच्छ वातावरण वाले स्थल का चयन करें। टीकाकरण के दिन सत्र की तैयारी। हर सत्र से पहले 150 ग्राम ब्लीचिंग पाउडर को 5 लीटर पानी में मिलाकर घोल बनाएं और सत्र स्थल एवं फर्नीचर को पूरी तरह साफ करें। चौक के द्वारा 2 गज की दूरी पर गोले बनाएं। हितग्राहियों और देखभालकर्ता के बैठने की उचित व्यवस्था करें। कोरोना एवं टीकाकरण संबंधित पोस्टर सत्र स्थल की दीवार पर लगाएं। सत्र के दौरान सत्र से पहले अपने हाथों को 20 सेकंड तक साबुन एवं पानी से धोएं व टीकाकरण की पूर्ण तैयारी करें। हर समय 3 प्लाई मास्क या घर का बना हुआ मास्क पहने रखें और ध्यान रखें कि कोई भी चेहरे से मास्क न हटाए या फिर अपने हाथों से मास्क को न छुए। किसी भी प्रकार की सतह से न्यूनतम संपर्क रखें। 1 घंटे में 5 हितग्राहियों को ही टीकाकरण कक्ष में एक के बाद एक आने की अनुमति दें।
Was that enough, Dr. Shukla? Is that okay?
Thank you. Thank you. It's all over. Thank you on my side.
Oh, thank you.
Yeah.
Dr. Brigu, would you like to?
Many thanks, Dr. Shukla, for sharing great experience from Madhya Pradesh and bringing in new ideas, new ways of dealing things. And thank you so much for sharing this all across. And you see, I think the power of innovation lies at the state. From Dr. Sinha, you saw how they have used across field level experiences to create messaging for their people in films. From Dr. Shukla, you see how animation can reach that message to every child, every community, every parent. So these are very clear learnings. In times of COVID, we are doing our best to start that across. Thank you so much, sir. Thank you so much for sharing your time and your thinking, and congratulations to you and your entire team. I would now request Dr. Danish to take it over further.
Thank you, Dr. Brigu, and thank you, Dr. Shukla. I would now request colleagues from Northeast. As we know, Northeast is one of the difficult area for us, not only for immunization, but also for other programs also. So let's see how Northeast is performing on immunization and what they are doing. Over to you, Dr. Subhajit and Dr. Ashish, for sharing the example from Northeast.
Hi, thank you. I think I'm audible.
Yes, please go ahead.
Yes.
Clear.
Okay. Thanks a lot for for giving us the opportunity to tell us about Northeast. I and Dr. Subhajit were looking forward to it. Could I have the next slide, please? If you see the overall immunization coverage for the northeastern states for India, this is the clear cut representation for the Indian scenario, the UIP for India. We have managed to reach around 70.8% population in the immunization coverage, the total immunization coverage. There is a marked increase if we see regarding the immunization coverage in the IMI districts. So this is actually, the focus is actually improving. Even during the COVID times, could I have the next slide, please? Even during the COVID times, if you see, if you see the state comparison, states like Meghalaya and Nagaland have actually done a good amount of immunization. They've increased the immunization coverage during the COVID as well. During the lockdown as well, the services were intact. There has been a very good market jump in Meghalaya. From 60%, they have gone up to 90%, 94%. And this is actually a very commendable job. Nagaland has a very small jump, but still 1% jump is there. Nagaland has been staggering at around 52% since a very long time. So this jump is actually during the COVID time. It is an actually indication of the state government being proactive even during the adverse times like COVID. Could I have the next slide, please? If you see our immunization targets, again, the similar thing, I'm just showing it percentage wise, it's a clear indication, a jump in Meghalaya from 60.5% to 95% approximately, and in Nagaland from 51.5% to 52.85%. Rest of the states, if you see, there has been a decrease, and this decrease has been because of COVID. Arunachal Pradesh sessions have gone down, Manipur sessions have gone down, not so much, but still 4% sessions have gone down. Mizoram sessions have decreased by 4%. Sikkim, again, there has been a market reduction of around 15%. Tripura sessions have gone down by 6%. This is because of COVID. This is the COVID problem we see regarding immunization services when the initial lockdown was there. Next slide, please. Again, if you see, the IMR is quite high. The Indian IMR is at around 33. In Assam, we have one of the highest IMRs, which is exceeding the Indian average of 33. Arunachal is quite high. Meghalaya is at par with the national average. Rest of the northeastern states, despite having a poor routine immunization coverage, the IMR is quite low. This is a paradoxical situation, and last year we had a very big discussion at the respective state levels for Manipur, Nagaland, and Tripura and Mizoram, sorry, for the determinants of low IMR in these states, despite having low institutional birth, as well as despite having less immunization coverage. Could I have the next slide, please? Again, if you see, then these are the total number of facilities as well as the cold chain points. We have around 970 odd cold chain points in, this is including Assam. We are having around 970 cold chain points throughout the northeastern states, out of which majority are functional, but still there are challenges in terms of improving the facility structure, improving the cold chain points. Could I have the next slide, please? Over to Subhajit, please.
Thank you, Dr. Ashish. Definitely, Northeast is a separate, it's having a separate, different demographic, different geographical challenges in India. So it has a separate kind of structure. So if you see this slide, so as showed by Dr. Ashish in the previous slide, the evaluated coverage showed by the National Family Health Survey, so it was not at par in many states. But after that, there was a intensive immunization program has been planned, and in this program, there was a lot of intervention done by northeastern states. And if you see this graph, Assam in the left and in the between there is northeast states. So in all over the country, average there is only 18% increase. These are all evaluated coverages, not the reported coverage. But if you see Assam, it is more than 30% hike, and also if you see for the northeast states, it is more than 20%. So it's more than the national average. So the first point what I want to share you that definitely in spite of the challenges, northeast had done pretty well to improve the immunization coverage. Next slide, please. Yeah, but definitely suddenly this COVID pandemic came, and it posed few challenges. So the first challenge was like sudden disruption of the routine immunization activities due to lockdown, as it was discussed repeatedly. Second, the health workforce. The health workforce is meager, it's not too much. So those health workforce, they were told to support the activities for the COVID management, like surveillance and other work. So they were not be able to do the immunization activities. Third is that we are now changing to more telecommunication and all. But if you know that in Northeast, the connectivity is very poor. So it's very tough to reach to the frontline workers. So it's another challenge. The fourth challenge which I want to flag is ensuring vaccine availability in the remote pockets. We'll show you some pictures. There are far-flung pockets and how to reach vaccines. So that's another challenge. And another thing, it came that there was a common generalized fear among the healthcare providers and also the community, because to gather together or something due to the messages on COVID. So that's another challenge for for structuring an immunization session. Another challenge is that inability to mobilize community at session site, because the frontline workers, the mobilizers, they were not able to visit the homes, the households to convince them, to persuade them. So definitely the mobilization was inadequate. And the last is that increased vaccination time because of the social distancing, the physical distancing, or the infection prevention control, these measures. So ultimately the vaccination time increased. So these are the challenges what is being faced by the Northeast states due to the COVID pandemic. Next, please. Yeah. So definitely, as we know, with the challenge, we may have the resurgence of the vaccine preventable infectious diseases. There may be measles, rubella, there may be diphtheria. So we control COVID, but we may have a resurgence of other vaccine preventable diseases. So this is the challenge. Next, please. So these challenges, what it has done, it has brought opportunities. It has brought few good options to us. What are the opportunities for the health system, for the immunization system itself? There is an overall general awareness on infection prevention practices. It's a very good. The community is aware now. Second is that there is a widespread discussion on vaccines. That is leading to a demand generation. So that's also another interesting and very important point. Third is that there is highest level of political and bureaucratic commitment. What we can see now, the chief ministers are leading, the health ministers, the principal secretary, the chief secretary, they are doing regular meetings. So the commitment for the highest officials, so that's helping the structure, the process. For another point, the fourth point is the convergence. So different departments, different sectors, they're coming together. So that also is another point. So these were we thought that these points were required, but earlier those points, the opportunities were not available, but now these opportunities are available to the system, for the immunization system. The digital means, this is the digital means being used more. I can give an example from Mizoram. So Mizoram, what the ANMs are doing, they are making small WhatsApp group with the mothers, and they're calling out the mothers, giving all information through their WhatsApp group. So these are kind of small initiatives by the digital means what they are doing. And last is the resource availability. So the availability of those masks, gloves, the PPEs are other requirements. So those were, but earlier they were not available, whatever the amount, but due to the visibility of the program, now it is quite well available to the whole system, whole the immunization system. So these are the things. Next, please. Over to Dr. Ashish.
Yeah, hi. So basically during the lockdown, as Subhajit was saying, during the lockdown, basically the state governments realized that this is not the way forward. And we also, along with the WHO colleagues, advocated that lockdown should not mean that immunization services should also stop. Meghalaya already had a very poor coverage. So the Meghalayan Principal Secretary, he immediately issued an order of continuation of services during the lockdown. Similarly, actions were taken in most of the states after WHO's and UNICEF's intervention. The services were resumed. So this was actually a very positive thing. The states started outreach sessions. The VHSNDs were in place, and the coverage improved. And all this while taking social distancing in view. So this was actually a very good outcome. As you can see, the communication letter from the government of Manipur is there, which highlights the need of immunization, the need of starting the immunization services, routine immunization services during and post COVID. So this is actually this intervention was taken up by jointly by WHO and UNICEF. This was quite a good initiative. Next slide, please. Could I have the next slide, please? Yes. So basically, more than 90% of the sessions, fixed sessions, were resumed, and around 70% of the outreach sessions were resumed. So this is during the COVID, when most of the states were facing a challenge in resumption of services. We had actually already resumed the services. Immunization continued, but in certain areas where the cases were high, there we had to stop the services as per the advisory. And then basically all the states, after the government of India had issued the advisory, all the states resumed the immunization services. Vaccine distribution was hampered initially, but resumed later on. So we have around 970 odd cold chain points, as I had earlier said, and there was no shortage of vaccines. This is actually a very commendable job by the respective state governments. Every single thing was taken into consideration, and most of the vaccines were made available so that no child goes unimmunized. States were ensuring COVID-19 guidelines during the immunization sessions. Next slide, please. Could I have the next slide, please? Could I have the next slide, please? Am I audible?
Yes, Ashish, you are audible. Just
yeah, you are audible.
Yeah. These are some glimpses from the Northeast during
Doctor,
the immunization
is this
coverage.
the right slide?
Yes, this is the right side. These are the glimpses of immunization coverage.
Okay, thank you. Sorry, there's some internet connect.
There's no problem. So these are the glimpses of the immunization services during the COVID. This is from Mizoram. Next slide, please. Could I have the next slide, please? Yeah, these are the slides from Meghalaya. Social distancing in place. Manipur, similarly, social distancing in place during the immunization in progress. Similarly, in Meghalaya again. Next slide, please. Could I have the next slide, please? We did have the supply chain and management issues initially, but extra effort and coordination was required, and after which the vaccine delivery system was in place. Inadequate vaccines for RRB, for example, in Manipur and Meghalaya was there, which will be replenished soon. Finalization of microplan, submission and finalization of microplan is in place. Both NPSP, WHO, and UNICEF, we are working along with the respective state governments to ensure that microplans are in place and sessions are being followed as per the microplan. Many of the planned sessions are not being conducted due to the ongoing lockdown, but as I said earlier, the sessions will be in place as soon as the microplans are ready and the services are resumed. Next slide, please. Dr. Subhajit, I would request you to please carry on.
Okay. So basically, if you see this slide, nice to see that you see we have told you that the challenges. What of the challenge was to reach vaccine remotely. So what the people, the workers, what they have decided. So they have decided to break all the barriers. You see the people crossing the river, people is climbing and trekking in the hills. You see the people, they are going through jungles. So this is how the vaccine delivery ensured at the Northeast states. So these are the examples from various states. So the state names were given. So these are the classical examples that how vaccine being delivered to the farthest of the corner where the last child is sitting. Next slide, please. Yeah. So another intervention. So I will show you different interventions. So first I have shown you that reaching vaccines at the last mile. Another thing, that virtual training, the review meetings. So now, as we know, we are doing today virtual training. So here in the left top figure, you can see the Commissioner Secretary of Assam. He is chairing a meeting with all the health workers. In the left below, you can see the Director of Health Services of Arunachal. He is reviewing, allowing the State Immunization Officer, the immunization program. In the right, you can see the State Immunization Officer of Arunachal, along with the development partners. They are training all the district level officers in the far flung areas of Arunachal. So this is a new mode. Also, we have seen that this is being done by almost all the Northeast states. Tripura has done specifically well for these virtual training review meetings to reach to all the workers. Next slide, please. Yeah. So definitely there is a huge debate on social distancing. So I will tell, okay, physical distancing also, definitely there is a physical distancing and also there is a emotional distancing. There should be physical distancing. There should not be any emotional distancing. So you see that how the health workers, so they have arranged in the left figure, if you see that in a tea estate in Tripura, the ADM sub-plant station. And in the right, you can see at a station site plan at a Mamit district of Mizoram in the far-flung areas. So they have taken the update what to do in COVID, and they are doing it at the farthest corners of the country. Next, please. Yeah. So this social distancing, or again, I want to reframe it as a physical distancing. You see in the top picture, that's now in the Northeast, the rains have started. So you can see the mothers, they are waiting in the rains with the umbrella, maintaining social distance to vaccinate their kids. It's in one of the PSC in the West Jantia Health Districts of Meghalaya. In the top left, you can see in the chur areas of Brahmaputra, the people are standing silently in their locations to get their children vaccinated. Below, you can see from Assam. Also below in the right, you can see this is the innovation by Changlang district of Arunachal, the easternmost district of the country. They have innovated, they have made umbrellas where the mothers will be sitting because the rains have started. So mothers are waiting there. And by this, they were maintaining the physical distancing. And below the picture, you can see it is in Tawang district of the Arunachal. It's there, still now the snowfall is continuing. There also people are maintaining social distancing. Next, please. So another important aspect, the third aspect is the hand washing practices. You see, hand washing, definitely hand washing with the soap and water. This is one of the most preferred way to prevent most important public intervention in this COVID situation. You can see in the left top, in the chur areas, the mothers, they were explained how to do hand washing. Then in the boat clinic, this is a boat clinic in the top bottom. So they were washing their hands and then they are boarding the boat to get their services. Also in the right, you can see from the Northeast states, a mother are carrying their kids in their back, and this is a common practice in Northeast states, and they are washing their hands and they are entering the station. So these are the real practices happening in the farthest of the country. Next, please. Yeah. So another important is the intervention is mothers meeting on counseling, because you need to impart all the informations to mothers, the caregivers. They are very important stakeholders of these immunization and all these activity. In the left side, you can see that in Assam, the ANM along with the Asha and Anganwadi worker, they are sensitizing all mothers. All mothers are standing by maintaining social distancing with their masks on, with their kids in their back. So this is how they're imparting. In the right, you can see in the Nagaland one ANM, she is giving the messages. And also that below in the right, you can see that in Arunachal, there is the these meetings are going on. So they are maintaining all the respiratory etiquettes in the farthest of the country, and they are imparting this knowledge. Next one, please. Yeah. So another important component is monitoring and supportive supervision. Look, it's for intervention. So these are very, very important interventions that you are motivating your team, you are supporting your team. In the top left, you can see the Director of Family Welfare of Assam. He is visiting one farthest district of the state. It's called Kokrajhar. This is in the Bodoland area, Bodoland territorial area. He is visiting and monitoring the session, and he is motivating the health worker. In the top, in the left side, in the below, you can see the State Immunization Officer of Assam. She is monitoring the cold chain equipments. In the right side, in the top, you can see one District Immunization Officer of Tripura. She is monitoring house to house. This is excellent example. She is going house to house and monitoring whether kids have received vaccine along with the ANM. And in the top below, in the right side below, the WHO Surveillance Medical Officer, he is visiting in the field asking that whether the child has received vaccines, with all the child is okay or not. So this is doing the monitoring and supervision. So these are the major interventions they are being done there in the Northeast states. Next, please. Yeah. So another innovation. So Assam has done a wonderful innovation. So there was, as it was discussed, that World Immunization Week was scheduled from 24th to 30th April. So just before that, the immunization services were resumed. So what Assam team has done, they have developed this innovative IC with the World Immunization Week and with the social distancing or the physical distancing messages, the hand washing messages together. This was done in English and in also the local language. You can see that only on that week, they have catched up, because during the lockdown, many children were not vaccinated. So they have catched up, and they have done 7,200 sessions, and more than almost 50,000 or 60,000 of the kids, they were vaccinated. So this is a wonderful practice. It was done by the Assam team. So these are the innovations what I want to tell. Next. Yeah. So the reaching the unreached. So that's another innovation. You can see in the top left that in Arunachal, Tawang district, still the snowfall is ongoing. I know that at Delhi it is very hot, but it's Tawang snowfall is ongoing. So the team is reaching there just in front of the house. They are vaccinating. You can see. In the right side, you can see in the Char areas, the boat clinics, because they are crossing the Brahmaputra, the mighty big Brahmaputra, and they are giving the vaccines. And in the top below, you can see that as you are aware, that the Northeast, the roads are not very in good condition, and already rains have started. So there's the vehicle which have taken the vaccine, it got stuck in mud, and now the ANMs are pushing that. So these are the recent examples of what has been done by the Northeast states. So they have tried their best to reach the unreached. Next one, please.
Sorry, just a quick intervention here, requesting the speakers to expedite the presentations, please.
Yeah, so we have only 2 slides. So summary and way forward, it's like immunization, as discussed, is the most cost-effective preventive health intervention, and we have to ensure uninterrupted services. So that's the first way forward. There are challenges and opportunities due to COVID pandemic, but we have to utilize those challenges and opportunities to structure the immunization delivery system. So like that, we have to do the capacity building of the frontline workers. That awareness we have within the community, we have to utilize that to generate demand. The efforts to reach the unreached has to be sustained. Like you have seen that they are taking vaccines by trekking, by walking, all those. And the last is that to efforts to maintain infection prevention practices within the health workers and the community to be sustained. Next, please. Yeah, Dr. Ashish.
Yeah, hi. Basically, as per the guidelines issued, the action plan would be that outreach sessions will be continued. Only in the buffer zones, the red zones, like for example, in the Dhalai region of Tripura, the vaccination coverage is not going to, the routine immunization coverage is not going to be there. But rest of since most of the northeastern states, the areas lie within the green zone or the orange zone, services are likely to continue there. All health facilities and outreach sessions, as I said, Dhalai is the only region, the aspirational district of Tripura, where it will not be continued. Realignment and structured microplan is being finalized. As we speak now, our consultants are working along with our consultants and the SMOs are working along with the respective state governments to ensure the completion of microplanning. Increased number of outreach session is being planned so as to reach the unreached, as Dr. Subhajit was saying. Strengthening of VHSND sessions under the proper microplan is going to be taking place. Extension of timings at the health facilities as well as the outreach sessions. This is because of the social distancing norm. At one time, many people would be able to enter. So therefore, sessions need to be extended now. We don't want sessions to be overcrowded. And that is the main reason a certain extension of timings is going to be there. Implementation of tribal immunization strategies in Manipur, Mizoram, and Sikkim is going to be there. And strategies to improve and strengthen routine immunization as approved by in the ROP is taking place. I would also like to thank the partners. Actually, whatever we are doing during this adverse time in Northeast is not just due to WHO or UNICEF. It is a collective effort of all the partners as well as all the state governments under the leadership of all the MDs, the respective principal secretaries and the respective MDs. Only we have been able to tackle such a huge task. And similarly, there are multiple organizations which have actually helped us in delivering. Behind the scenes, many people have worked together for facility assessment as well as for completion of certain activities, which was not which could not have been achieved only by one person or one organization. It is a multi-sectoral kind of a task. And I would like to thank everyone for this.
Yeah, next slide, please. Yeah, so thank you. What Dr. Ashish is stating that we want to thank, but just this slide also speaks a lot. In the left side, you can see this is the supply because the health workers are crossing through a narrow bridge, this wire bridge, to reach to the child. And in the right, and you can see in the Sikkim, a child is eagerly waiting to take the vaccine. So we have to send the vaccines, and the child definitely, the child requires that vaccines. And definitely the teams at the field, the frontline workers, the ASHAs, the ANMs, the medical officers, the program managers, the state immunization, district immunization officers, really the kudos to them. Thank you everyone.
Thank you.
Thank you so much, the entire Northeast team. And as said, let me again reiterate something very important. You saw that the entire presentations were in pictures, and these pictures do not depict any one person effort, any one organization, anyone. It is an effort which is led by a team run by the government under the leadership of the state governments and supported by partners like WHO, UNICEF, UNDP, CHAI, Gates Foundation, ITSU, PATH, every place, and a full-fledged team is working behind that. So thank you to every team and thank you to every member. And I acknowledge, and as I said, this is presentation from what all of you are doing. Okay, so thank you so much. Moving on to the next sessions, and because we have been quite a bit delayed, so this is a request to Dr. Narayan and to Dr. Bhatnagar to condense their presentation in 3 minutes if it is possible. Sorry for doing that, but if it is possible, please be very short. Things that have been said, if you can skip, and things that are new, please bring it on. So let me introduce Dr. Narayan to this session. Dr. Narayan brings in a very special perspective of how do we engage private sector in immunization, and a full-fledged work that has been done by Gujarat, and bringing in that model for other states to learn in. So Dr. Narayan, let's jump into the crux of how do we do that and move forward. Over to you, Dr. Narayan.
Thank you so much, Dr. Brigo. I'm really thankful to Ministry and colleagues in UNICEF and all the partners for this opportunity. I would like to share some of our unique experience in working with private sector for improving immunization coverage in the state. Can I have the next slide, please? See, Gujarat, we have a specific challenge. The large number of people go to delivery in private setup. If you see the SRS data, it was almost 47%. Now, if you see our HMIS data, more than 60% deliveries are happening in private setup in Gujarat. And number of children seeking care for ARI is almost 65% is from private. Children seeking care for diarrhea is almost 46%. And for immunization, state average, almost 13% people seek care from private sector, and urban is split higher. So this is just to tell you the private sector in Gujarat. Next one. You see, if you see in India level, the private sector is overall 9%. You see Gujarat, it's 13%, but disintegrated data will show urban 21%. And if you look into some urban areas like Surat, it will be almost 30%. Next slide, please. So when we are actually following our Prime Minister's, kind of a message, every district should have more than 90%, national level and state level 90%, every single district should have more than 80%. We are wondering how we can do this coverage with, with so much of private sector also present in Gujarat. So we thought we should have innovative approaches, partnership, area-specific strategies, and bottom-up approaches, and we have to do something different. This was there when we actually were thinking to engage the private sector in a bigger way. Next one. Next slide, please. We undertook a rapid assessment of situation, knowledge immunization practices in Gujarat with the support of CDC Atlanta and government of Gujarat, medical colleges, and we published a paper in Vaccine Journal, which actually given us a lot of information. There are a lot of eye-opening situations. There were some good practices, but there were a lot of areas to need improvement. But I'm not going to the details of the paper, but I would like to give you some idea we got from this assessment. Next slide, please. See, looking in this slide, it shows you a real picture of what were the perspectives of people of private sector to get into partnership with the government. You just look at the extreme right side here, 44% people were saying we'll allow the government to use our facility to administer free vaccines to the public. 44%, some strongly, some lightly agreeing. And there were some vaccines from the government in exchange for me to reporting the number of doses given, and I could not charge any fee. So large number of people were ready to do this. And there are some people said we received some vaccines from the government in exchange for me to reporting the number of doses, and I could charge a fee. So there were these three different kind of information. There was another response which we said we will listen to the guidelines, but we'll do our own. We don't want any exchange of information. This was another thing. But however, they were ready to listen to the guidelines coming from UNICEF, WHO, government, and they wanted to do changes themselves. This gave us some idea that if you can stretch our arms, go to the private sector and work with them, we can establish something good for the system. Next slide, please. So we came up with an idea, thanks to our convener, in IAP and also the lot of IAP active members. We came up with a plan. They said, let us also contribute for your coverage targets of the state. So we came up with a plan called Impact, immunization practices to improve, achieve coverage targets. We named as an impact strategy. We came up with a module, short course, taking ideas and suggestions from our Government of India guidelines and also IAP guidelines, and developed a half-day module. And we created a pool of more than 80 experts in private sector who can train more practitioners in private sector. These guidelines were used for the communication, dissemination, many IAP conferences. Academy of Pediatric Gujarat made a special appeal to their pediatricians to do something extra to improve coverage in Gujarat and also improve the quality of immunization, cold chain, and vaccine management. So Gujarat government is very in the private sector, and they encourage private sector for coming forward for vaccination, for VPD and AEFI surveillance. So we thought if we can work together, we can increase public awareness, better cold chain management, both in public sector and private sector, and improve better, improved record keeping, which can also give us a good, platform when our coverage evaluation surveys are done. If the record keeping is done well, it will pick up right information. So there was a proposal of a public-private partnership, which we actually discussed with the government to support the private sector in engaging them in a bigger than before in immunization services. Next one, please. Next slide, please. Yes. when the COVID situation happened in Gujarat, it was 19th March was the time when we had first reported COVID. We thought many of the private sector the clinics, in urban areas, in hotspot districts got closed, or they reduced the working hours. So we thought we picked up support available with us with the medical colleges, and we partnered with the obstetric society and also Academy of Pediatric Gujarat. Thanks to my colleagues in medical colleges in Ahmedabad, Surat, Baroda, and Rajkot, we could do a rapid assessment using Google Sheet. Around 670 people, private practitioners. Almost 49% people said they are continuing their services as per routine, but number of people turning up reduced. But there are many people who have to adapt to the changing situation. They have a scheduled session only on a fixed day, almost 16% of them, and a fixed time, I should say, and remaining 8.7% did only fixed day. Earlier they were doing every day, and around 11% completely suspended vaccination. You also should notice a greater population of obstetricians, 18% have suspended their vaccination services as compared to pediatricians, and fixed time vaccination services for all beneficiaries were being carried out in 25% of the pediatric facilities. Turnout of beneficiaries were very poor, even if the clinics remained closed. So we thought even during COVID, not only during routine, we should do something to engage private sector partnership in immunization. Next slide, please. Next slide, please. So we have the Ahmedabad Corporation, Surat Corporation, Baroda, where our actually high priority districts because of the number of cases. So we had established a public partnership strategy to resume immunization services in Surat city. Increasing COVID cases and lockdown have reduced the availability of vaccination services in a big way in the cities. And public partnership was established between the Surat Pediatric Association and Municipal Corporation Surat. You see in the picture, and our mayor of Surat inaugurating a public partnership, an activity in a pediatric setup. And on the, we also have a deputy municipal corporation commissioner. She is also a medical doctor, and you see our Surat Pediatric Association president on the other side. They actually came forward, and I really appreciate the enthusiasm and the activeness and the support of Surat Pediatric Association coming forward. Around 100 of them came forward to provide their facilities, and they also given all the distancing, hand hygiene, promotion, and the government could give them all the required support also with respect to logistics. So technical support for micro planning, capacity building was given by UNICEF and WHO partner. I'm thankful to our SMO, WHO in Surat, and this model actually is helping us now covering a good number of children in urban area who otherwise would have missed immunization. This is complementing the effort, ongoing effort of the government. Government is doing a lot of work in, following all Government of India guidelines in a green zone and orange zone. But in some places we needed a confidence building for the parents also. So these pediatricians who are volunteering to support came very handy, and this partnership is working very well. Next one, please. You see the pictures, engaging the fathers, mothers, and following all the precautions, which is mentioned in our Government of India guideline, is being followed. And I'm thankful to our SMO, Dr. Chirag, also for sharing these nice pictures. So this work is actually really inspiring us. So we would like to take it forward to remaining cities. Next slide, please. My last slide. So effective partnerships are need of the hour, and coming together and contributing can make a positive difference in the life. I'm thankful to Government of Gujarat and also our IAP, Foxy, medical colleges, and development partners in Gujarat, UNICEF, WHO, UNDP. In your states, you'll have more partners. As Bigu mentioned rightly, building partnership with everybody, including CSO partners, will really help us, and everybody brings their different skill sets and experiences. So working together, we can really contribute to increasing coverage and quality of immunization even during COVID. Thank you so much. Over from my side.
Thank you so much, Dr. Narayanan, for bringing the important component of private sector engagement and lessons from Gujarat. I compliment you for completing the entire sharing of entire learning in 3 minutes time. So thank you so much, Dr. Narayan. And next important component of the program is community engagement. So I would now like to invite Dr. PC Bhatnagar to share his presentation, and I would again request him to be brief, try to complete it in 3 minutes so that we are able to catch up some of the time. So over to you, Dr. Bhatnagar.
Thank you, Dr. Danish. Can I have my first slide, please?
Yes, just a second. I'm starting my screen.
Okay, just next. So now I won't repeat whatever has already been said through. So just bring next slide. Next. Okay, so basically we are doing a project for community engagement with the UNICEF and Government of India, and basically covering the 40 blocks in aspirational districts in Northeast, Odisha and Andhra. And basic community involvement mechanism is through engagement of the CBOs and CSOs. So how we are going ahead in this particular time. So local CSOs and CBOs are being trained on COVID-19 and engaged in various immunization promoting activities. So as earlier speakers have said, we are using this opportunity of COVID, the challenges associated as an opportunity, and building the awareness level both of the local NGOs as well as the community-based organization. So they will help in disseminating the messages, and then you have seen all the support which was being required. So they will support the ASHAs and ANMs in identifying and line listing of the high risk and left out children. Next, please. Identifying the inappropriate areas if we have to conduct outreach sessions in alternative locations. Help in organizing the immunization sites by supporting in maintaining the COVID-19 preventive measures such as physical distancing, ensuring the use of masks by the beneficiaries, etc. Like in one slide, earlier slide, you saw the ANMs and all will be drawing the spheres to show where people will stand. So some of those work can be taken up by our CBOs, especially the Mahila Mandal and those groups. And then we will also be using that opportunity for demonstrating the hand washing at particular site, and local CBOs and NGOs will ensure that there is availability of soap and water at the immunization sites. Next. So they will act as a link, will be the focal point for the community members. And what we have also done, we have identified some influencers among the community, and we are also sharing their numbers with the community so that they are also a source of proper information. Many times health workers find it difficult to reach, and nowadays health workers are, especially frontline workers, they have lot of things on their plate. They have to work for COVID, they have to work their routine activities. So these people will be a major support for peripheral health workers, and they will also act in counseling the community, particularly the parents, because as of now there are a lot of panic and fear. So with correct information, they will be able to communicate correct information to the people, and they have already started doing that in certain locations. Next. So that is what we are, how we are going ahead. So there will be community consultations. Again, we are not going with for a large number of consultations with large number of people. We will follow the guidelines. Then miking and announcements from religious places like temples and mosques, hand washing demonstration, engagement of influencers, as I've already mentioned, community mobilization activities, especially IPC, use of mass media, as well as some of the wall writings and wall paintings. So those will be the things. And then our workers with helpline access to the community through their phone number, acting as a helpline for the community. Next. So what we have already done, these are some of the locations in Assam, particularly Hailakandi, Dhubri districts, where we have conducted the initial trainings. As of now, we are working in 40 low performing blocks of 16 districts in these states, that is Assam, Andhra, Arunachal, Manipur, Nagaland, and Odisha. And each block we are identifying 40 to 50 such CBOs, CSOs, and influencers who will be closely working. So their initial training, including the online as well as physical, has been completed, and now they will be closely working with the local government officials, working through the micro plan, working with the development of micro plan and other support which is required. Next. Next. Yes, so this has already been explained to you. We have already completed the training, and now some of the other interventions. Now this is a invite. Basically our concern is that there should not be too much of gathering at one place. So this is an invitation letter which we will be filling for each child and giving the specific time decided in consultation with the local ASHA and ANM. And this will be given to each family so that large gatherings on the immunization sites can be prevented. And this will also help them with the key messages related with social distancing. This is just one of the example of the things which we are proposing to take up as a part of our community mobilization interventions. Next. So thanks. I think I've tried to finish within the given time. So it's open for questions.
Thank you so much, Dr. Bhatnagar. It was really an excellent presentation, and very well describing how community and community-based organizations can support us. Because of lack of time, we are directly going towards the limited question answer section, and I would request Astha to take it forward. Astha, over to you.
Thank you, Dr. Brigu. Thank you all panelists and speakers for speaking. Sorry that we had to cut short the panel discussion. But we have some very interesting questions from the participants, so hopefully that will make up for that. Now let me ask my first question to Dr. Sinha. Dr. Sinha, a question from the participants was, with migrants returning to their native places, how does the government plan to ensure the pregnant women and children from this section get their due or missed doses? Would you like to please answer that?
Yes, sure.
Thank you.
Like I mentioned in my presentation also, that the pregnant ladies are sent directly to home quarantine. And when our teams are going, we have a very definitive structure of ASHA.
Your voice is breaking. Your voice is breaking.
Okay, that means we are just a minute. Yeah. We are increased.
Doctor, sorry, you're not audible at all.
And now I think Dr. Sinha's video is frozen. I'm not sure if it's only for me.
For all.
Okay.
Yeah, his video is frozen.
Maybe we can go to the next question, and then when Dr. Sinha is back, then we can ask him to maybe address that again. Would that be okay, Dr. Brigu?
Yes, I think let's do that.
Okay, sounds good. Okay, I'll go on to my next question. This is for Dr. Shukla.
Yes.
Dr. Shukla, the question asked in the by the participants in the chat box is 30 minutes waiting after the session still necessary? Question mark.
Can you repeat?
It says, is 30 minutes waiting after the session still necessary?
Yeah, definitely yes, because we have to ensure that no adverse event following immunization occurs. So it's very valuable and we should adhere to that. Definitely.
Great, crisp answer. Thank you, Dr. Shukla.
Thank you.
We'll move on. The next question is for Dr. Ashish and Dr. Shubhajit. The question is, the children, instead of taking to centers, HWs can go door to door. Is that recommended?
Okay. So this is not recommended as per the Government of India guideline, because the sessions has to be set up in some kind of area where there are a lot of processes has to be followed. So because otherwise there is a chance of adverse event following immunization, what Dr. Shukla has just mentioned, because there are different kind of vaccines. Some vaccines has to be dissolved and it has to be discarded within 4 hours. Some vaccines have to be kept within the holes in their ice packs. So there are different modalities and aspects. So for the pulse polio immunization, as it is given orally, it is taken, it is given house to house. It can be given, but for the routine immunization sessions, we can't go house to house. The ANMs, the ASHAs, they can go to the villages. They can go and sit in a convenient locations. They can call and mobilize the mothers with their children. They will come and they will follow the practices of infection prevention, and then they will give the vaccine. So this is the official mandate.
Thanks so much, Dr. Shubhajit. Just ensuring that, Dr. Ashish, did you have anything to add to that, or did that cover everything that you were thinking as well?
That covered everything that I was thinking about. Thank you.
Perfect. Thank you so much. Oh, sorry, I was speaking with my mic muted. Apologies. My next question is for Dr. Bhatnagar. Dr. Bhatnagar, the question that has arisen is, how were the ASHA and ANM and other health workers prepared for outreach and health facility sessions during COVID-19? And what about the mothers and children who have been missed due to the pandemic for vaccination? How are they going to be tackled and record maintained for them?
So actually, as I said, that as of now, ASHAs, ANMs, though they are being trained, but their training and everything is at a limited level. That is one part. Second part is they are also quite overwhelmed with their whole work related with COVID-19 also in certain situations. And whatever said and done, community is also not prepared for immunization and all. And that is where our community mobilization, though at a low level because of limitations imposed by COVID, particularly not gathering of all and all that part, but bringing community into play, including the PRIs, religious leaders, and village self-help group and all. That is proving to be quite helpful. These are the people who have become a kind of extended arm of existing ANMs and all. These people are helping them in identifying the high risk as well as the low door families and then reaching them, helping them in all that part, and also selecting in alternative venues for immunization. But as now immunization has just started, so these things are taking time to pick up and work through.
Thank you. Thank you for that, Dr. Bhatnagar. Thank you for sharing. We'll have last two questions. We see Dr. Sinha is back, and there is also a question for Dr. Narayan. So let me start with the question for Dr. Narayan, and then we'll ask Dr. Sinha the same question we asked him before. Dr. Narayan, the question that's coming up is, what is the percentage of private immunization clinics receiving vaccine from government stores in Gujarat? And what is the reporting system?
There was an urgency for getting immunization restored in Gujarat. So for the COVID, we started in Surat city, where almost 100 receive vaccine in their facility, but our vaccinator is A&M of the health system. So the vaccine is delivered to the facility and immunized by them. So for general immunization services, there is actually I should call mixed practices. Some places it is restricted to polio campaigns and for the MR campaign, things like that. But for the routine immunization, we have a city specific practices. So I'll not be able to give you the exact number, which our state office will be, immunization officer will be able to share. But what I want to highlight is, at that time of need, there need to be support mobilized from private sector to complement the effort of the government, so that we reach all the mothers and children with life-saving vaccine. Over.
Thank you so much, Dr. Narayan. Thank you for sharing that. Now let me just quickly check that Dr. Sinha is back with us. Dr. Sinha, can you hear me? Oh, maybe I have to make him the co-host again so he can unmute his mic. Sorry about that. Dr. Sinha, can you hear us now? And could you please?
Yeah, I have unmuted my mic, and thank you. I got disconnected in between. I'd like to tell you that in Bihar, the migrants we are coming, the pregnant ladies and children, very small children, they are sent for home quarantines unless they are symptomatic. So in home quarantine, when they go, and our teams, nearly 80% of the sessions are being held. So the team which goes, the mobilizer which goes house to house to look for the people who are to be vaccinated, they even go and ask for any newcomers. And that is very clearly one thing which we learned from IMI and MI and extended GSA and GSA, that we were forced to make Google sheets and work overnight and in the night, late nights, and make Google spread and all those things to get the data. So we use this strategy, and daily basis I get data that how many children has been vaccinated and how many pregnant ladies have been vaccinated. Based on that, the current data which have been provided to me right now shows that previous footfall was 3 pregnant ladies per session. Now most of the sessions it is going from 4 to 5. So we can understand that there is an increase, and the increase is there. And similarly, there is an increase in the children vaccinated. We are covering nearly 1.2 to 1.3% extra. And we are calculating this in terms of rechecking this in the terms of vaccine use utilized from EVIN, and both are matching. So these things which has paid, and I think we are going in the right track as far as the pregnant ladies who are coming as migrants. Is it okay, or you want some further clarification on this? Okay, I'll fix the battery.
Thank you, Dr. Sinha. Sorry, I cannot tell whether you've covered everything because I'm not an immunization expert. Okay, I think if there are no further comments, can I invite Dr. Brigu to say a few words? And if not, then maybe I can go ahead with a quick thanks and closing of the session.
Thank you.
Thank you, Asta. Thank you and first of all, thank you everyone for joining in. Okay, I know it takes time and it takes your precious time to be part of this, but it has been a great learning altogether, cross learning. I have learned personally so much from different states of what is happening, and I hope that you must have also learned many things that you are doing, or you can appreciate how good you are doing it. There are multiple questions, and there are multiple questions. The chat box has first of all, thank you so much for your all kind appreciation for everyone for organizing this. The intent is fully met, that we wanted to connect with you in this COVID time where personal connections are difficult. Second thing, you have given us a large number of suggestions which we have collected, and we will take it forward. So your chat box comments are not going waste. We have collected them. There are some things which are very good suggestions. We will take them as suggestions. There are some very good questions where we don't have a real answer as of now. We will take them to find those answers. And in this entire piece, we will take immunization to the next level. I would also like to thank all the speakers in this for taking that time and coming forward to brief everyone of what is happening. It's a very good initial piece. Yes, in 1.5 hours, you can't cover a session like immunization. An immunization session needs a discussions of 2 days, 3 days continuously to just capture everything. But we have tried to touch in some major points. Finally, again, a very important point that I would like to communicate is this entire effort is not anybody's one individual effort. This entire thing that states have presented is nobody. And I would like to acknowledge everyone. And let me start now by doing a reverse acknowledgement. First, let me acknowledge all the partners from the community, the CSOs, CBOs, NGOs, community members who have taken this up and taken that forward. Let me acknowledge all the UN partners, UNDP, excellent work being done in the entire Northeast, in all states, taking even has become benchmark, which takes forward the entire vaccine and logistics management to WHO, UNICEF, and all partners who are there across. And then finally, to our leads, our champions, the government, Dr. Aldar, Dr. Agarwal, Dr. Sinha, Dr. Shukla, and all the SCPIOs who are not there. This is just, we have taken Dr. Shukla and Dr. Sinha, but SCPIOs from every state, cold chain officers from every state, everyone gets involved. As I said in the beginning, it's a team effort. It's no one's work. It is a team effort, and the team will ensure that no child in this country remains unimmunized or not fully immunized. Let's take that pledge. Let's move it forward. Thank you for joining in. Thank you so much, the entire SPEAR team, for being part of it. Thank you, WHO, and thank you everyone for supporting this co-hosting piece. Asa, let me give you the mic to close it across.
Thank you so much, Dr. Brigu. That was the nicest closing words I've heard in a long time. Thank you so much for your acknowledgement and your appreciation. Let me also extend my thanks to all the speakers and the participants for coming in. I'll just take 1 more minute of your time. Oh yeah, and thank you. Somebody reminded us in the chat box that Glenda has been staying with us, and Glenda has been helping us out, and she's doing that with a smile. Thank you so much, Glenda, for your wonderful contribution to today's seminar. And now I'll just take a minute to just share my screen, and then we will wrap up this meeting. Just 1 second. I hope everyone can see my screen now. So just a quick reminder that those of you who have participated in today's session, you will receive your certificate of participation, and also the presentations that were shared by the speakers today. We will also upload them on our website. So it's called sphereindiacovid19academy.org. Please go to this website after 24 hours, and you should be able to download your certificate and also access the presentations that have been shared with us today. Please note that our next session is tomorrow at 4:30 p.m. It's on postnatal care for mothers and newborns during COVID-19. So all of you might also be interested in attending that session. After this, we will be sending you all emails as we do on a daily basis, and which will have the link to register and more details. For anything else, feedback, suggestions, questions, please email us at covid19academy@sphereindia.org.in, and we'll try and get back to you as soon as possible. Thank you so much, everyone. Please have a great evening, and we will see you in the next session. Thank you, everyone. Goodbye.
Thank you.
Thank you. I will be ending the meeting now. Thank you.